Good evening, everyone, and welcome to our webinar today as well. Today, as you can see, we have a topic on why IVF with donor eggs may fail sometimes and the reasons and prospects for patients. Our guest here today is Dr. Natalia Schlarb from IVF Spain, who you've had a chance to previously also see during our past webinars. I believe you are familiar with her. If not, you will have a chance to listen to her presentation. And let me remind you that the presentation will take 20 to 25 minutes. And after our presentation, the Q&A session will follow. So if you have any questions, you can type them all in our chat section, and afterwards all the questions will be answered. Just also let me remind you that this webinar is being recorded, so you will have a chance to watch it again tomorrow, and it will be published on our site as well. And if you have any questions, just please go ahead and ask them just after the presentation. And I guess let's not waste any more time and just start with the presentation. I believe you can see Dr. Natalia is right here with us. Dr. Natalia, are you ready to start?
Yes.
Perfect.
Let's go.
Perfect. Let's do it. Go ahead.
Carolina, thank you so much for the great introduction. For those who do not know us, I'm having webinars once a month with egg donation friends about different topics in IVF, in egg donation, in endometrium issues, immunological issues. Today we will discuss the reasons why people choose egg donation, what are the indications to egg donation, and we have to be aware that egg donation is the highest step in fertility treatment which we can offer to our patients, but there are some complicated cases where egg donation fails. I will explain you why, what are the reasons. So let's get to the point. The problem is that women now, especially in Europe, are very modern, independent. They study, they grow their careers, and they delay their maternity plans. So through the development of birth control pills in the 60s, we can move our cycles however we want to. And it also allows us to grow our careers. And at the age of 35, this is an average age where a modern European lady thinks about having children. The problem is that our biological clock is not aware of these changes, of these political changes. So we see that before we are 35 years old, we generate about 50% all the embryos which are genetically normal, which are healthy. So the best age to get children is before you are 35 years old. The problems start between 35, 40 years old. We see that at the age of 38, 40, only 30% of all the embryos that we generate are healthy. At the age of 41, 42, just 17%. And when we are older than 42 years old, only 11% of the embryos are healthy. So basically in IVF Spain, from 43, 40 years old onwards, we counsel people for egg donation. The euploidy rate by donors, we have to be aware that even though the donors are young, there are no donors with 100% euploidy rate. I have seen in my career the same donor in one cycle having all embryos genetically normal, and the same donor in the other cycle having just one embryo, which was genetically normal. The beauty of Spanish legislation and reproductive medicine is that we are allowed to do trophectoderm biopsies, means we are allowed to develop embryos till day 5, till the blastocyst stage, perform trophectoderm biopsy, means our embryologists are trained to take 3-4 cells out of each embryo and examine those DNA of those cells to define which one of them is healthy. So if we see the pregnancy rates of patients with their own eggs, which are older than 35 years old, without genetics, without trophectoderm biopsy, the pregnancy rates are under 20%. If we put technology to those embryos, we see that if we define 3 genetically normal embryos of somebody older than 35 years, the cumulative pregnancy rate per cycle is 91%. If we have egg donation cycle to this curve, we have to be aware that there are 2 ways of defining which of embryos that we have is the best one to transfer. One is to put embryos to the special incubator called time lapse that is watching if embryo has reached certain stages of development in a certain time. We use it in IVF Spain through Gary, and then the pregnancy rate per transfer is about 70%. When we perform genetical testing of embryos, means instead of watching them in incubator, we allow ourselves to take a couple of cells out of each embryo and see which one is healthy or not, because we are aware that there's no donor in the world with 100% euploidy. Then the pregnancy rate per cycle is over 90%. When we focus a lot of our attention on the genetical quality of embryos, the endometrium for a couple of years in reproductive medicine was kind of forgotten. In IVF Spain, even though we were performing genetical testing of embryos, in some cases, I was still not able to achieve pregnancy. Every patient in IVF Spain before transfer gets something called mock cycle, test cycle, where we put patients on oral or transdermal estrogens. And on day 10 of a cycle, we perform transvaginal scan to see how thick the lining is. In complicated cases, especially with recurrent implantation failure, we need to perform the uterus lining biopsy. Means on day 21 of a substitute cycle, where patients are on estrogens and transvaginal progesterone, we perform not only the scan but also the uterus lining biopsy. In IVF Spain, this is an office procedure where in gynecological chair the patient is put like through the simple smear test, where with the PPEL we aspirate a little bit of the uterus lining and we send it to immunological testing and to receptivity testing. When we see the results, what is it all about? The results for receptivity are coming back and they are very straightforward. Means The patient with 5.5 days of transvaginal of progesterone could be receptive, pre-receptive, or post-receptive. In order for embryo to get accepted through the lining, there has to be a certain timing for that. We have to be aware that in the uterus lining there are immune cells that can see embryo as a foreign body, NK cells, Th1, Th2 cells, and also there has to be a certain communication between those cells. And this communication is summarized through the test called endometrium receptivity assay, where we know exactly if 5.5 days progesterone opens implantation window, if this is the perfect timing for embryo to arrive to the lining to get accepted or not. I started performing receptivity assay about 5 years ago, and it was a very complicated German patient that have never had a positive pregnancy test in Germany and also with us. With the second egg donation cycle, the last embryo that we transferred was with the receptivity of 7 days. Means the test that we have done showed us that the patient was pre-receptive. Then we corrected the dose of progesterone, confirmed the biopsy. The confirmatory biopsy came out with 7 days receptive, and this was the first time where the patient achieved a pregnancy and live birth. This encouraged us to perform a receptivity assay test basically after first transfer that in egg donation did not achieve a pregnancy. I do not wait for recurrent implantation failure in egg donation. I do not wait for 3 transfers which failed. Basically, if the first transfer with embryos of a good donor did not result in a pregnancy before the second embryos transfer in IVF Spain, we performed the lining biopsy to failure with own eggs, where the pregnancy cannot be achieved in their home countries. They're coming for egg donation, and then the egg donation through good quality of embryos of a young donor can be converted eventually to a good prognosis patient. We have to be aware that in egg donation cycles, the pregnancy rates are age independent, means if somebody is 35 years old and suffers of premature ovarian failure, or if there's a patient in her menopause, in her late 40s, early 50s, we still can achieve the same pregnancy rates. In order to talk to patients about certain quality and high pregnancy rates, the key is blastocyst development, genetical testing of blastocyst will define when in egg donation cycle it should be performed, receptivity assay and immunology. So day 5 embryos are called blastocysts. They are a lot different from day 3 embryos. Day 3 embryos are called morulas. They have just 8 cells, 10 cells. So you can imagine if somebody makes a progress from 8 cells to 150, 200 cells in 2 days only the strongest embryos are going to make it. And this is the natural selection of embryos. In IVF Spain, egg donation is the highest level of reproductive medicine which we can offer you. there are certain steps of choosing the donor. The classical matching of donors is performed in 4 steps. The first step means that egg donation in Spain is anonymous. We can only offer you anonymous donors. You will never see a picture of a donor. You will never be able to choose yourself a donor. You have to have so much trust in us, in our team, that we select a donor for you, sticking to certain rules. According to the Spanish law, we have to generate a child that will explain the combination of you. So when we meet one day and your child will run around us, everybody has to think that you are a genetical mom. So we have more than 500 donors available for you. We speak regularly to young students that they should have children before they are 35 years old, or they should perform social freezing to have eggs frozen for themselves. And then if somebody performs social freezing and decides to be our donor, we offer then social freezing for free. The donors that we have are tested also through psychiatrists. No schizophrenia, no major depression disorder, no personality issues allowed. Genetical recessive diseases in European population like cystic fibrosis, muscle dystrophy. In the second step of donor choosing process, you will be asked to fill in the phenotype questionnaire, where you will have to tick boxes. How tall are you, color of hair, color of skin, what is important for you, which characteristic of yours your donor shall have. You will be also asked about the blood type match, if you see it as something important or not. We will also explain you how to speak to the child about egg donation, if communicated to the child or not, and in which way that the child is from egg donation from Spain. We also will need your pictures. When we have all this information, we put your data to the computer. Computer will show us 20 best donors available for you out of 500. And then eventually all the doctors that work in IVF Spain, we meet every week, every Tuesday. We discuss all complicated cases with negative results, and we also performed donor matching. Means before your donor is chosen, I have to introduce your case to my colleagues which speak different European languages. They introduce their patients to me, and this is how we find the best donor for you. In selected cases, we receive patients from African Americans from the United States with sickle cell disease, with thalassemia, where we match donors also through genetical test in order to be sure that donors are not only carriers of the most common diseases in European population, but also the population-specific diseases. For patients that did fail first egg donation cycle in IVF Spain, or patients which we receive from different clinics which fail egg donation cycles in different clinics, we do not only perform the phenotypical match, the way you look like, but also we want to look deeper into your case. We do not only perform your receptivity assay test of the uterus lining, but we also perform the immunological testing. There is the very well described KIR AA inhibition through HLA-C1 embryos, first published by group in Chicago, Hilby et al. And in IVF Spain, we were able to confirm it. So sperm analysis andrology is very straightforward. In IVF Spain, we perform always basic sperm analysis according to World Health Organization criteria from 2010, where volume, concentration, motility, and morphology has to be examined. We also performed more extensive test where we perform DNA fragmentation. If we see high fragmentation and any issues with the sperm analysis, the patients are put on vitamins. We have a certain protocol, and then are invited to fertilize eggs with the fresh sperm sample. If we see that everything is okay, that the sperm analysis on the day of first appointment comes back normal zoospermic, everything is okay. We freeze this sample, and then we fertilize fresh eggs of a donor with the frozen sperm of a patient, and we have the same pregnancy rates and same blastocyst rates with fresh results when the sperm quality is good. So in order to talk about high success rates in egg donation cycles, we have to develop embryos with a blastocyst and either put them to time-lapse incubators, or to be more sensitive, we have to perform genetical testing of embryos. The serious reproductive medicine in egg donation starts with exclusive egg donation programs when patients are offered 16-20 eggs of a donor. In IVF Spain, we give patient guarantee of 5 embryos, 5 blastocysts are guaranteed, and then if we perform genetical testing of embryos, we see that either one or all embryos could be genetically normal. That's why statistically the euploidy rate in egg donation cycles is about 70% if we have more than 6 blastocysts. So complicated cases, sometimes it takes them a longer time to understand why they cannot get pregnant, especially when they have low AMH, low ovarian reserve. Then we perform cycles called embryo banking, means we generate 3-4 blastocysts in one cycle, 3-4 in the following cycle in 2-3 months, to achieve the magic number of 6 blastocysts. And then age dependent, we see there is 4 or 1 genetically normal. This is what some patients achieve in couple of cycle. Donor basically achieves in one cycle. Donors are young with high AMH. In order to be a donor, you have to have AMH more than 2 nanogram per milliliter, more than 6 antral follicles, and then your euploidy rate is about 60-70%. So here are the pregnancy rates of IVF Spain in 2016 without genetical testing and with genetical testing. So these are the clinical pregnancy rate per transfer. Without genetical testing, the clinical pregnancy rate per transfer is 60%. Clinical pregnancy rate per transfer with genetical testing is about 75%. Last year it was 77%. The cumulative pregnancy rate means pregnancy rate per cycle after 3 consecutive transfers is more than 90% in IVF Spain. So the problem that we have is the major problem that we have is the genetical quality of embryos, which is age dependent. And as you see here, even though somebody is young, can be a donor under 30 years old, 28 years old, we see that there is a low number of genetically abnormal embryos that this person can generate. Before coming to Spain, I used to work 12 years in Germany, and I remember from my own experience, also young girls in Berlin coming to gynecologists looking for help because they were pregnant with trisomy 21. So the older we are getting, the more genetically abnormal embryos we generate, but also young patients and also donors can generate embryos which are genetically abnormal, not as many as patients over 40 years old. When shall we perform genetical testing of egg donation embryos? So there was a paper published 2 years ago showing that in the United States there are different centers with different euploidy rates. Here we have different countries in Europe. What we have seen in our egg donation program, that euploidy rates are very high, are over 80%. So basically, when you are coming to IVF Spain, in the first attempt with the first donor, we do not perform genetical testing of embryos of this donor routinely, but we are still aware and we inform our patients that there is a 20% aneuploidy rate of embryos of an egg donor. So when you see this paper and there are centers with 39-40% euploidy rate, of course, in such center, you should test embryos of a donor routinely. If you have a center that is specialized in egg donation, in IVF Spain, we run more than 600 egg donation cycles a year, then and you see this euploidy rate, then PGS, genetical testing of egg donor embryos, is performed usually when the second egg donation cycle is done, because the first didn't work out. What the euploidy rate seem to depend on the protocol which is used to stimulate to achieve the eggs of a donor. We have to be aware that the protocols are AMH dependent. Each donor, before it's allowed to be a donor, is screened for infectious diseases karyotype AMH. And then when somebody has AMH2, means good ovarian reserve, you get 225 units of hormones that stimulate the follicles grow. When somebody has AMH5 or 7, means you have a great ovarian reserve. You're going to generate a lot of eggs. So that's why the goal in egg donation cycles is not to produce too many eggs. The goal is to achieve 20-25 eggs maximum to have a good quality of them. And of course, somebody with AMH7 will receive just 150 units of hormones to stimulate the follicles grow. Aspiration methodology is very important. There are centers where there's a lot of things going on in operating theater, and the negative pressure which is used is too high. What can we expect? That the eggs through this negative pressure are changing their shapes, and that the quality of this kind of embryos could be lower. So it's very important to adjust the pressure when we perform the egg retrieval, the culture medium and pH. A lot depends on the boss of the lab, who is in charge. I can tell you that the embryologists that I work with are my blessing. There are very well trained. We have 4 senior embryologists. We know each other professionally very well. We are also friends. But these people, when they come to work, they are very focused on this, what they do. They basically just perform biopsies of the embryos. They have no time to perform egg retrievals with us or transfer. These procedures are done by young embryologists. So the success depends a lot on the gynecologist that knows which dose of hormones should be given to certain donor, which is AMH dependent, but also depends a lot on the lab, how the lab is organized, and the experience of people in charge. Here, one of the last slides that I have for you today. So, as I discussed previously, the serious reproductive medicine, the serious pregnancy rates start with 16-20 fresh eggs of a donor. The protocols, FSH, LH, adjusted to your AMH. In the last 2 years, we performed more than 20 cycles, PGS cycles a month, especially when the second PGS needs to be performed, when IVF Spain has such a high euploidy rate. Probably not. I believe that in the future, the clinics who will be able to show this kind of euploidy rates will be able to survive, and PGS will be a factor which will allow to decide of the quality of this lab. Of course, the prospective study with the bigger numbers are needed. I think that's it for today. Thank you very much for listening. Today we have in Spain bank holidays. So it's a Spanish Father's Day. If there are fathers from Spain or all around the world, I wish you on that day take your decisions and become patient of IVF Spain. Thank you.
Perfect. Thank you so much, Dr. Natalia, for your presentation and explaining us everything, I believe. We will now go to our Q&A session. There are many questions ready for you, so let's not waste time and go ahead with it. What is the success rate % for a 5th day blastocyst?
Okay, if I have the day 5 embryo without genetical testing, the clinical pregnancy rate means gestational sac with a heartbeat. 60% of cases is positive. When I have embryos with genetical testing, it depends. In IVF Spain, 2016, 2017, it's about 75, 77 clinical pregnancy rate per transfer.
All right. Thank you so much for the question as well as the answer. And let me have a look at the next one for you.
Mm-hmm.
We've had 2 failed donor transfers and one era. What difference does a second era make?
Okay, so you have to see when you have the there are different timing, endometrium timing tests available. The one that we use tells us exactly if you are pre-receptive, receptive, or post-receptive, and indicates how many hours more or how many days more progesterone you need to be receptive. And the first test that we perform is with 5.5-day progesterone. The confirmatory biopsy is usually done with when the result comes out to be pre-receptive. The confirmatory result is done with 6.5 days progesterone. If the result comes back pre-receptive again, then we recommend either 7 or 8 days progesterone. 7 is quite common. 8 in my entire career, 8 days progesterone I've seen maybe 3 times in my entire life. So in selected cases, especially when you belong to recurrent implantation failure in egg donation, means 3 transfers with good quality blastocysts of a donor and not pregnant, there's no mercy, there's no trust. It has to be verified. The timing of the lining has to be verified very specifically. I hope this could answer your question.
All right, perfect. Thank you so much for this question as well. And let me have a look. Here it is, the next one. What is the price for fresh egg donation?
Okay, in IVF Spain, we have prices depending on the quality of embryo, the day development of the embryo, and how many embryos we guarantee. The best programs that we have, first one is called exclusive egg donation, where we give you a guarantee of 3 blastocysts of a donor, 3-day 5 embryos, and the price is €9,700. When we talk about exclusive plus egg donation, we give you a guarantee of 5 blastocysts. This program gives you a lot security, means if we see that the cycle with the donor didn't go the way we would expect it, and we just have 3-day 5 embryos, 3 blastocysts, and you are not pregnant, then the new donor has to be stimulated for you without any extra cost to fulfill the 5 blastocyst guarantee. Then in one package you can have 2 donors, and it's €10,700. We have a diamond program with pregnancy guarantee, where we offer patients 3 different donors. There are 9 transfers in total. The last cycle is with the sperm donor, and this costs €25,000.
Perfect. Thank you so much for explaining this to us as well. And let me have a look at the next question for you. Here it is. Does thyroid result matter? Mine was 2.44.
Thyroid results do matter. In internal medicine, we want TSH to be between 0.4 and 4. In reproductive medicine, we want TSH to be under 2. So basically, if you are between 2 and 4, internal medicine doctor will say it's okay. In reproductive medicine, we treat it. Why? It's super easy to understand. The baby in the first 3 months of development needs folic acid and thyroid hormone for the proper brain development. So that's why the TSH in our reproductive I'm not sure if you guys can hear me. There is a problem with the connection.
Yes. If you could just repeat it, we didn't hear the last part of your answer, okay?
Yeah, so internal medicine here sees thyroid not as strict as reproductive medicine. In reproductive medicine, we want TSH to be under 2. All the results more than 2 are treated. All TSH under L-thyroxine are controlled every 3-4 weeks. The reason for this is that in the first trimester, in the first 3 months, baby for the proper brain development needs thyroid hormones and folic acid. So that's why we need to give more thyroid hormones. That's why TSH has to be lower.
All right, perfect. Thank you so much for letting us know, of course. And let me have a look. My first fresh donor egg transfer ended in a missed miscarriage and since had to fail frozen transfers. Last cycle had prednisone, progesterone, Proginova, baby aspirin, Clexan, and intralipids and still failed. Only have on 1 frozen embryo left. What tests would you recommend?
Okay. If, as we see, immunology has been covered, the clotting has been covered too. The first question is, how old are you? Are the embryos transferred genetically normal or abnormal, or this is an egg donation cycle? And how high are the euploidy rates of this egg donation center? The question is, are embryos healthy or not healthy? Some embryos look good, have a good morphology, but still are genetically abnormal. So this will be my first question. And the second question will be, what is your lining doing? What is the timing of your endometrium doing? So I would consider before the last transfer, the uterus lining biopsy, to see how many days progesterone you need to open your implantation window. Last week, you can imagine, it was a very busy week for me. I had 1 doctor visiting from 1 country. I had 2 guys visiting from UK, and what happened was they were very interested in receptivity testing. So basically, we send or give doctors that collaborate with us a kit for receptivity assay, and then if you want to, we can send it home to you. We can develop collaboration with your doctor to check it before the next transfer. So feel free to drop an email to our patients at ivfspain.com, and then we'll be more than happy to help you.
Thank you so much for this question and answering this one as well. And let me have a look at the next question for you. Here it is. Would you recommend 1 or 2 blastocyst transfer to improve success? I am 41.
When we talk about blastocyst culture, we recommend always single embryo transfer, because the twin rate with blastocysts is over 30%. We have to be aware that twin pregnancy for us are always high risk pregnancies. It means you have to go to the doctor more often. Your cervix length has to be monitored, and when the cervix is too short, we forbid you to work, we put you to the hospital, and then for you it means C-section. In Europe, And in the United States, nobody delivers twins normally anymore. Okay, so definitely single embryo transfer.
Thanks so much. We have another question here. We have adenomyosis and MTHFR gene mutation. So would I have chance of implantation with adenomyosis? I've had 2 miscarriages, a stillborn, and 2 failed IVF.
Your adenomyosis is just an immunological factor for us in the first 12 weeks of pregnancy. Adenomyosis is endometriosis of the uterus wall. So basically, when patients are downregulated, the endometriosis or adenomyosis is not growing anymore. And when patients are put on basically prednisone, in reproductive medicine is given until 12 weeks of pregnancy to make immune system calm down. So with prednisone, majority simple immunological issues, we can take care of them very well. The problem that you have, madam, and I do not like it, are 2 miscarriages and stillbirth. The most common causes of miscarriages is genetical quality of embryos, which is age dependent. So you definitely, if we still work with your own eggs, you definitely need a cycle with genetical testing of your embryos. Stillbirth, I do not like it at all. Means patients with stillbirth are always counseled through hematologist for factor V mutations, and some of them deserve, even though in hematology everything is okay, but because of stillbirth, I would consider in your case giving you Clexane until you deliver. So this is how, knowing only this simple information that you're giving here, this is how I would approach your case.
All right, let me have a look at the next question for you. We have had 3 failed donor IVF transfers, and our clinic is now advising a KIR HLA test. How will this improve our chances?
It depends which KIR and HLA are you. If HLA is matched to your KIR properly, this will bring you to pregnancy rates of everybody else in egg donation. The problem that we have with KIR and HLA is that KIR AA is very well published and established. KIR B, I can tell you from experience, we ourselves, we struggle. So if you are KIR AA, the case is pretty straightforward. With KIR B, it still remains a challenge.
Perfect. Thank you for this as well. And let me have a look. And would you recommend PGS testing for all egg donation blastocysts?
Yes. Why? You can imagine I started doing myself PGS testing and egg donation because I received patients from Berlin, and I'll never forget it. This was a case that changed my life and changed reproductive medicine in IVF Spain upside down. The patient was offered an exclusive egg donation program. We generated 6 good quality AB quality blastocysts, and the patient kept having miscarriages. And you can imagine, I was trained in Berlin, so it's a very small world. Doctors know each other. The patient came back to me with a result of her cytogenetic examination from the miscarriage material. And it turned out that she had a miscarriage with trisomy 13 embryo, and they were embryos of a donor. So you can imagine that after this kind of cases, doctors get a lot more gray hair at once. And I was nervous. I was expecting a lawsuit. But on top of this, both of them were lawyers. So a patient came back and said, no, we want to continue working with you. We are happy. But the second egg donation cycle that we have to do, we ask you to do it with PGS. And the patient got pregnant with those PGS embryos, transferred immediately. The first child born in Europe through egg donation was born in Berlin, in a hospital which I know very well. And this is how it started. So in 2016, we reserved PGS for second egg donation in patients who failed first donor. And we were able to see that with PGS, we have better results, shorter time to pregnancy than without. So I think that PGS is the future. In IVF Spain, you have 80% euploidy rate. So if we should do it routinely in this moment, no. But I think in the future, this will be a standard.
Okay, thank you so much for this. And let me have a look at the next question straight away. We had our last frozen embryo transfer in November. What's the best time to try again?
Timing is one thing, but the second thing is we have to focus. Why did the first transfer didn't work? What happened? Is your endometrium growth proper? The anatomy, the thickness? Is there timing that the receptivity has been performed or not? This answers should be given before the second transfer will be undertaken. I do not like to transfer in the same protocol when the first transfer didn't succeed. I always want to change something, and we can transfer every 2-3 months. But if we keep repeating the same, we are, it's like taking USMLE test and repeating the same mistakes in the test. So at the end, you're going to fail. So you have to see what have you done wrong to improve it and to try again.
All right, thank you so much. And let me have a look at the next question here. Is there a bad and good care result? How does the care test helps you in egg donation?
No, there is no bad and good care. There are things in medicine that are examined and better known than the other ones. So in transplantology, when we transplant to somebody kidney or liver, we have to make sure that the blood type matches, that certain HLA are matched in AB subtypes. With KIR AA, we know because Hilby et al. From Chicago, they published a couple of years ago that KIR AA accepts C1 embryos, and in IVF Spain, I was able to confirm it. About KIR B, there's no papers published. KIR B is very inhomogenic, means some KIR Bs react as AB, some as BB, And then sometimes it takes two donors to find which immunology this KIR-B accepts better. So there is still place for reproductive immunology to maybe not say KIR-B, but take a look to the KIR-B genetical expression subtypes and saying this KIR-B, if there is no DS4 or DS5, this is KIR-B which accepts C1 embryos, and if the other receptors are missing, this maybe accepts C1. So medicine needs to take like a deeper look to KIR-B. KIR-A is known, so it's not a problem at all.
All right, thank you. And we have a follow-up to the question, in fact. So let's have a look at this now. Do you match the donor KIR to KIR woman with the donor, or KIR donor to HLA of the male partner? How does the KIR HLA matching work?
We match KIR to HLA. So your KIR as a recipient is the one which decides which HLA of a donor you need. We do not only match KIR to in egg donation cycles. We also take a look in IVF cycles, and then if there is a KIR mismatch, then we put patients on immunological protocols. The reason for immunological protocols with tacrolimus, the medication which is allowed for kidney transplantation, started in IVF Spain 2 years ago. A friend of mine, gynecologist, was my patient, and she needed my help. She came with tacrolimus protocol from Germany, and I understood that certain KIR demands certain HLA of a donor, but it's not enough. In order to talk about success with certain KIR HLA mismatch, you need not only prednisone but tacrolimus granulocyte protocols. So in IVF Spain we have it defined with which problem, immunological problem, what kind of protocol we recommend to our patients.
Thank you so much. And let me have a look at the next question. How soon after a failed egg donor transfer can you try again?
Basically, you can try in the next cycle, but the question is, does it make sense? I would recommend you to use one cycle to find out why the previous transfer didn't work. What is your immunology doing? What is your receptivity doing? And then transfer in 2 months. So give yourself a month to find the diagnosis, what has gone wrong, and then transfer.
Here's the next question for you. I've had 2 failed donor egg cycles in the last number of months. My clinic don't feel we need to do an ERA test, and as I've had a successful pregnancy previously on egg, do you recommend prior to our next transfer?
I have seen in my career patients receptive with 5 days, and they were getting pregnant with the first egg donation cycle. And the same patients I've seen 2-3 years later with 7 days receptive with the second egg donation cycle. What can I say? If you failed 2 egg donation cycles, you need to know what is going on. Is it a problem of low euploid rate of egg donation embryos in this cycle? Is it a problem of your immunology? Is there a KIR HLA mismatch? Is there a receptivity window? Yeah, and these three factors need to be examined. So if your clinic doesn't feel they need to do something after you failed 2 egg donors, I'm not sure if this is the right approach. I would like to know myself, yeah, what is the problem? I wouldn't like to have one donor more, good quality embryos. Are the embryos day 3, day 5 development? These are details that need to be looked into deeper. Okay, so if you feel psychologically strong enough for the 3rd egg donor cycle, I invite you to be a patient of IVF Spain to check at least 3 main reasons why it has not worked before.
Okay, thank you so much for explaining this to us as well. And then let's have a look. How old are your donors on average? Is it possible to have their name or some sort of contact in the future?
Donors, according to the Spanish legislation, have to be under 35 years old. In IVF Spain, we want them to be under 30 years old. No names, no pictures, no contact with donors are available. We can only tell you age and blood group of a donor when you are pregnant, nothing else.
Perfect. Thank you for explaining that for us as well. And let's see. Many doctors say Iratal tears the implantation window only in the tested cycle. What is your opinion?
No, it tests implantation window in a test cycle, but I perform to transfer. I performed the same type of cycle. We in IVF Spain we do not transfer anything in fresh cycles anymore. Everything is in substitute cycles. So patients receive 15 days estrogens, 5 days estrogens and progesterone. So I can move the knowledge from the test cycle to a transfer cycle. And from my experience, and I use the receptivity assay or receptivity map now more than 5 years. So from experience, usually the AirMap, the test that we are using in IVF Spain, holds the same result for a long time. What is changing the receptivity? A miscarriage, DNC, birth of a child, and even though somebody delivered a child and comes for the second one, we repeat the protocol of success. There are some cases that we repeated the protocol of success, it's not working, and then we verify another receptivity assay. So in some cases, in 20% of cases, 25% of cases, the receptivity is changing through these 3 things that I named.
Thank you so much. I am 45 and haven't had a period for 2 months. Can I still get pregnant with IVF? What are my chances of success with my own eggs with donor eggs?
Okay. Amenorrhea means you do not have a period. There are different reasons for amenorrhea. If somebody doesn't have a period for 2 months, does not necessarily mean that you are menopausal. You need to see your ovarian reserve, age, AMH, antral follicle count. Yeah, there are 3 factors of ovarian reserve. Now, when your AMH is less than 1 nanogram per milliliter, we know that getting pregnant with your own eggs is going to be extremely difficult because you are not going to generate too many eggs. And then your euploidy rate means number of genetically normal embryos in your age is less than 10%. You have to generate 20 eggs, 10 blastocysts, one of them will be genetically normal. I can tell you from my experience, I have never seen this kind of cycle in my life. The euploidy rate, the magic number for euploid embryos is maximum 43. I haven't seen anybody pregnant with own eggs older than 44. Yes, so definitely because of your age and euploidy rate, you should go for egg donation. And with your eggs, without genetical testing, the chance that you'll be pregnant is less than 10%. If I find genetically normal embryos in your eggs, the pregnancy rate is 70%. With egg donation, the pregnancy rate is 70%. But the problem is that in your age, you are not going to generate genetically normal embryos. I'm sorry, it's as cruel as it is, but it's better to see this chart, age-dependent euploidy rate, and be aware where you are and take proper decisions.
Okay, thank you so much for explaining this for us as well. We do receive questions similar to this one, so I guess all have been answered too. And let me have a look. Next question is very similar. We had one before like this, but if you could just shortly answer this.
No, egg donation in Spain is anonymous. Means we can only tell you age and blood group of a donor when you are pregnant. The child will never find out who the mother is in any age. But according to the law of this country, the child has to fit into your family, has to have the donor, has to have the same color of hair, color of skin, the same body shape as a patient. So when the child is born, everybody has to think that a patient is a genetical mom. I am aware that there are two worlds of egg donation. First, anonymous, and the other one, non-anonymous. This is something that we have in the United States or in UK, that the child at the age of 18 years old can find out who is the mother. In Spain, absolutely not. When you are becoming a patient of IVF Spain, we teach you how to speak to the child where their child is from. There are beautiful books in English where at the age of 2-3 years old, we recommend you to read a fairy tale to the child before going to sleep. And in this fairy tale, this is the first moment when the child understands that the part of the child is from Alicante. At the age of 8-9 years old, we recommend parents to go back to the clinic to show us, to show the clinic. People are coming back for Christmas, bring us tons of chocolate. I usually go with the children from one department to another. To donors I cannot go, but because they're in a different building in a different part of Alicante. But we go to the nurses, we go to the marketing department, and then children take pictures with us. They make like a family book. They put these pictures with us inside, and then I understand that there is a part of them from Spain. So psychologically, you have to know when to speak to the child. The best is before 10 years old to have the identity process closed. We'll be more than happy, to have you on a board and explain you how can we choose the donor for you in an anonymous way without showing you information of a donor, but how to make your life and the life of your child through the proper counseling as good as with an open ID donor.
Perfect. Thank you so much for giving us an idea of how it all works. I believe it is very important for everyone. We do have a few more questions. We will be slowly finishing, but let's try to answer some of them. I'm 33 and a half, premature ovarian failure. I'm having menopausal symptoms and considering starting HRT. Will that affect my chances of donor eggs working?
No, HRT, you have to be aware that the mean age for the menopause of women in Europe is 45, 50 years old. You are too young to live without estrogens. Estrogens make us feel young, make us look good. And you cannot live, with the side effects of not having estrogens. Then, when we need to do egg donation cycle, we put you on a substitute cycle with estrogens and progesterone, and you have the same success rates as everybody else who is having regular periods.
Thanks so much. And let me see, we do have another question here. We have had 3 failed IVF donor transfers. On our last attempt, we had an endometrium biopsy, an endoscratch, and intralipid infusion. What would you propose going forward?
I may sound like a broken record, but there is the first thing. Do we know if the embryo of the donor that we are transferring are day 3, day 5? Are they genetically normal, genetically abnormal? And then endometrium biopsy, did the result came back receptive? Is the dose at the time of the progesterone given to you being corrected? Intralipid, why? NK cells, have they been tested or not? I would consider maybe prednisone. I would consider maybe blood clotting, Clexane, aspirin to add. And then if the first egg donation cycle is not working, we have to see why.
Excellent. Thank you so much. And let me see, we do have another question. Hi, I haven't had my first implantation yet. I live in UK and normally send my ultrasound to IVF Spain. How will you know when my endometrium is ready for implantation? As you mentioned about the right timing. Also, after having a diagnostic hysteroscopy, my cycle is delayed. Should I be worried? By the way, I am 44.
Okay, in egg donation cycles, we erase your age. So the pregnancy rates in egg donation cycles are age independent. And how would I know if your lining is working or not? The first thing is a patient history. When patient is coming to you, you have to speak to your patient, and the 80% of success you reach when you are a good listener. If the patient tells you, listen, I have been pregnant 4 times in my life, I had 4 miscarriages, then you know that this lining is working. Then routinely we do not perform receptivity assay before the first transfer. If the patient comes to you and says to you, I have never had a positive pregnancy test in my life, so this is the moment where you should do the uterus lining biopsy or at least endometrial scratch to improve the implantation in the egg donation cycle. So this is how I know somebody's endometrium is working or not working.
All right, thank you so much. And we have another question. Would you always recommend a fresh transfer over a frozen transfer?
Okay, I'm going to say it and I'm going to sign it. In IVF Spain, we have higher success rates with frozen genetically normal embryos than with fresh ones. So if I have a young donor and I know this donor and I know that she has a high euploidy rate and I know that this lab has a high euploidy rate, you can go for the fresh transfer. But if I have, I hope you can hear me. But if I have a donor that is matching you phenotypically, but I know that she doesn't have a high euploidy rate, because I have seen, a couple of cycles with her before, then definitely you need PGS, and then you need, embryos which are genetically selected for you.
Thank you so much. I had chemical pregnancy in my last DE frozen embryo transfer. Do you suggest I follow some protocol in my next transfer? Does me having chemical pregnancy affect my next FET transfer?
The biochemical pregnancy is a very good news for us, means that the uterus lining is working, but you need to go further. You need to allow yourself for one transfer more, and maybe immunological protocol, maybe prednisone, maybe clexane, aspirin to improve clotting. This will be the way to go in the next transfer.
Perfect, thank you. And let's me show you the next one. Do you accept HIV patients?
Yes, we do. One of the most crazy presents which I've ever received were from my parents. My mom, a couple of years ago, desperately wanted me to go back to the United States and, overtake her office. It wasn't meant to be, but I was closed for 3 weeks in very famous school in New York, where I was preparing myself to USMLE. And believe it or not, the life expectancy of HIV people now through modern medication is the same as everybody else. What I am very specific about, and it has to be clear for everybody, when we work with HIV positive male partners, the sperm has to be washed, because we have to be aware that even though in your blood the viral load could be low, undetectable, under 5 copies, still in sperm, in the white blood cells in the sperm, there can be particles of HIV. So our lab, when we know that you are HIV positive, is always doing sperm washing, freezing, making a PCR of the washed sperm to make sure that there are no HIV viruses in the sperm. So we always, HIV patients are always, the fertilization takes place with the frozen sperm. So this is the first thing. This is the male part. The female part is super straightforward too. In Europe and in the United States, we have centers for HIV patients. You have to go to your doctor every 6 months, and then the medication has to be adjusted to you so the viral load is low, so you will have the same life expectancy as everybody else. And then on the day of a transfer, when we have a female HIV positive patient, then we are taking the look, when have she had the last HIV testing in blood, and how high the viral load was. And I'm famous in clinic for counseling patients that if the viral load is high, you cannot have a transfer. On the day of a transfer, you have to be undetectable. Your HIV viral load has to be under 5 copies in milliliter. All the children that we have in IVF Spain born from HIV positive parents are HIV negative. So through this hard work, sperm washing, sperm freezing, HIV undetectable on the day of a transfer, we have all children born healthy.
Perfect. Thank you so much for explaining this for us as well. We have only a few questions left. Let's have a look. I have 2 frozen embryos already. 3B, do I need hatching for my first implantation?
It's usually decided by the doctor and embryologist Yeah, the hatching embryos seem to implant better. So if the first transfer didn't work out, yeah, maybe hatching here, immunological protocol and blood clotting support, maybe this is going to help.
Okay, perfect. Thank you so much. We have two short questions from the same patient. First one is, what is the age limit? And the next one is there a weight limit at the clinic?
Okay. Age limit is 50 years old and 11 months. You can imagine that the oldest patient that we had in IVF Spain was 54. So there's a moment in your life where you have to see the law, but also a case and individual support for patients. Weight and BMI. There is no weight limit. We transfer embryos. The first transfer is done, and the patient weight is not important. If we see that you are more than 90 kilos, then we recommend you to lose your weight. We have one of the nurses working with us was my personal trainer and my nutritionist, and me myself, I lost more than 20 kilo with her. So we have a protocol. We teach you how to eat. That you have to have 5 meals a day, 3 big ones and 2 small ones, and then the weight training. Everybody's like afraid of weight. With weight training, you can lose a lot more than with cardio. Yeah. So if we need to talk about it, we'll be more than happy to support you.
Thank you. Okay, we have 3 questions left, so let's not waste time. And here it is. There is a study in the UK stating that intralipid infusions are not effective, and as a result, many UK clinics no longer offer it. What is your opinion?
Yeah, the intralipid with NK cells, there are no big prospective studies showing that intralipid improves pregnancy rates. I'm aware of this study, but I'm also aware of cases of patients with high NK cells in endometrium with intralipid. They got eventually pregnant. So in IVF Spain, when we see high NK cells in endometrium, we still perform intralipid infusions, but in endometrium.
Perfect. Thank you for this question and answer. And let's look at the next one. Are there any exceptions that the child can get the information about the genetic donor, for instance, some genetical disease or other cases?
Yeah, very good question. Routinely, never child can get to know who is the genetical mom. If we have a life-threatening disorder, somebody needs a bone marrow transplantation, super serious cases. I don't wish it anybody. We have to go to the court, and then the judge decides if we can give you an identity of a genetical mother and of the family. Then we have to go very individually, but routinely never the identity of the mother can be known through the child and a family. Never.
All right. Thank you so much for explaining this. And this will be our last question for today. So let's have a look. Spanish features are often dark hair, olive skin. What is the volume of fair skin? Fair blonde, hair blue, green eyes, egg donors.
Look at me. There is a lot of international students now in Spain, in universities, in the clinic. When you see our pictures on Instagram or Facebook, you can imagine that we are very international. So majority women. So there is a big Ukrainian immigration now to Alicante. In order to work correctly with patients, the 500 donors that we have are divided into 4 groups. Phenotype 1, girls with blue eyes. Phenotype 2, green. Phenotype 3, brown eyes. Phenotype 4, girls from Asia and Africa, difficult phenotypes. So our donor department has to make sure that we keep a balance in all the phenotype groups. Yeah, so it's super easy to find donor with brown eyes. So to fulfill, to make the phenotype 3 group complete, it's super quick for our donor department. If we see phenotype 1 or 2, it's more difficult, but in order to run so many cycles, knowing that donor can have 8 cycles or 6 live birth, donor department has to find donors with blonde hair, blue eyes, and green eyes, so we can run the clinic properly. It's more challenging, but through collaboration with universities, talking to students, and then it's word to mouth. One donor had with us good experience. She recommends us to her cousins, to her family. So the percentage with phenotype 1, 2, and 3 is even. It has to be 150 donors in each group. Phenotype 4, girls from Asia and Africa are more challenging. African donors we differentiate patients very well. We understand that a girl from Nigeria needs a different donor than a girl from Ethiopia. On top of this, one of our colleagues is half African, and she a doctor, so she differentiates different shades of black. I grew up in Detroit area, so I'm also aware when I look at somebody where this patient is from. Girls from Asia are more challenging. Waiting time is about 3-4 months, but it's still doable.
All right, perfect. Thank you so much. We had all the questions answers, I believe. But of course, if you have any other questions, please remember you can forward them to us, to our email patient@eggdonationfriends.com, and we will forward them to Dr. Natalia, and I'm sure she will be able to get back to you. Okay, I believe that will be all for today. Thank you for joining us. Thank you for your questions. And of course, thank you, Dr. Natalia, for being here and for your expertise and answering all the questions. It is always, always a pleasure. And I can't wait for the next time. Is there anything else you would like to add?
Thank you very much for listening. In the Spanish Father's Day, I wish all the fathers from Spain listening to me, or future fathers, to support their female partners in their dream of making family complete come true. I didn't have a chance today to talk much about andrology, but when you will come to IVF Spain, we'll be more than happy have you, help you, and explain you what can we do for you better.
Perfect summary. So thank you again, and have a good night, everyone. Hope to see you next week as well during our next webinar. Thank you. Bye-bye.
Thank you. Good night.
Good night.